Hello, my name is Garry Cooper-Stanton and I'm a registered adult nurse with over 16 years of nursing experience. I currently work within a clinical and education role within a local NHS trust, which also includes a background as a specialist in lymphedema, alongside my other role as a doctoral researcher at the University of Birmingham. I'd like to pass on my thanks to the JBI Evidence Implementation Network for the opportunity to develop this commentary and to contribute to the series. I'm here to talk about one particular study that I've read, titled Unfolding and Characterizing the Barriers and Facilitators of Scaling Up Evidence-Based Interventions from the Stakeholders' Perspective, a Concept Mapping Approach. The first author is Ziyanyan Shan and 5 others, based at the Beijing University of Chinese Medicine. The subject area of this particular study is focusing on those affected by dysphagia following a stroke, also known as a cerebral vascular accident, and the barriers and facilitators in supporting them in the community. Statistics around this area suggest 12.2 million people are affected by a stroke each year, with 1 in 4 of people over the age of 25 will have a stroke in their lifetime. In this study, 80% of post-stroke patients who returned to their communities after their condition had been stabilised, 54% still had dysphagia after discharge. They utilised a concept mapping approach within this, and it's one approach to engage with stakeholders in the design and implementation of strategies, and it's there to help to bring about almost a co-design, co-production by having a variety of views of those stakeholders involved. Now, this led to stakeholders being involved in what they class as the brainstorming and discussion around the subject, the sorting and rating of activities to reach a consensus of the best strategies to improve the implementation. In this study, it was a mixed method approach, and this was to take into account the subject matters or subjective matters such as opinion, followed by those opinions being objectively reviewed from a numerical stance, and that's where we get the quantitative. And this was through hierarchical cluster analysis and multidimensional scaling. With this led to a number of steps within this study. 1 was the preparation, 2 the brainstorming, 3 the sorting and rating, 4 the analysis, 5 interpretation, and then 6 utilisation. Now, the aim of this study was to identify the barriers of scaling up evidence-based interventions within a nurse-led service for the identification of post-stroke dysphagia and its management, and to assess their importance and feasibility within dysphagia as a subject matter. And this was via this evidence-based program approach from the JBI. And when they spoke about identifying stakeholders, they were speaking about family members, community medical staff, the research team, and those involved in setting up the previous dysphagia program that was already in place. This took this purposive sampling approach due to the focused nature of the subjects and who would be involved within this particular area. And this is why it was important. They were there to address the uneven uptake of research findings within that particular service and area and to improve upon clinical care outcomes. And this was to take forward an implementation science approach which promotes the systematic uptake of evidence-based practice into practice itself. And this is why we talk about the scaling up, was to scale it up, the evidence, into that particular area to ensure it's sustainable, that it's integrated, and that the healthcare system was equitable. And if we're talking about why dysphagia as an example, well, it's a common and serious complication after stroke, which is estimated to affect up to 78% of stroke survivors. And that's because of the poor outcomes with those with stroke patients with dysphagia upon the swallowing mechanism due to the neurological disruption as an example of stroke. And with that, those affected by dysphagia are 5 times more likely to develop aspirated pneumonia compared to those who do not have dysphagia. And this can not only lead to the physical effects of poor nutrition related to dysphagia and the swallowing, but also prolonged hospital stays, poor outcome from patients, and also the risk of infections through pneumonia. But it's also those psychosocial effects that also will affect the person themselves, but also those around them. And so when we talk about the methods and everything else that comes into play, The goal of this was to address the overarching aspects of the outcomes of dysphagia, what's leading to the barriers and facilitators, to improve the nursing service quality, and also the organisational approach to evidence-based culture construction within those communities. The use of the mixed method study design incorporated both those quantitative and qualitative aspects that come into play, which was mentioned earlier. But with that, the first step was to look at the subjective matters, the qualitative matters. And from that approach mentioned earlier, it was about the brainstorming of the barriers and facilitators for the goals mentioned above, and then the sorting and rating those via card sorting. After this was done, the analysis of the grouping statements were undertaken via objective quantitative method, and that was via cluster matrix that also used coefficients. And with that, they also utilised this GO matrix. And this all fulfilled that objective part of analysis and also interpretation. So with this, when it came to the actual results of the study, they were generated for those several steps. And this also included the several stages, which included the first stage of the classification of statements, which was 61 factors drawn into 10 secondary level clusters. And then these 10 secondary level clusters were then integrated into 4 primary clusters that characterise the stakeholders' views of barriers and facilitators. This then led to these being rated via the GOZO matrix, as they mentioned, which comprised 4 areas around the importance, but also feasibility. For example, one area might have been low importance and feasibility to high importance and feasibility. When we're looking at the high importance and feasibility side of things of the results, the one that came out as the top factor was the perceived needs of the community to deliver care as the most important, with other areas following as important, such as the shortage of human resources and the heavy workload in nursing, and the community nurses' lack of knowledge and skills to identify and manage dysphagia. When it came to the other side of things, of the least important and feasibility, was the costs and resources, mobilisation as the most least important, with the others being the community will have no significant personal changes or institutional reforms in the next 3 years. So when it came to that high importance area, what it enabled them to do was to look at what the community saw, or the stakeholders saw, as the most important. And with this, that could be used in conclusion to help the decision makers prioritise the most important factors to be considered when developing this further, and to get evidence-based practice into that particular service. When it came to the limitations mentioned in this particular study, they spoke about the representation of stakeholders at different organisations were invited, but due to the intensive nature and several hours of participation, some may have been deterred from participating because of the time factors. Also equally, because the design was different to what people were used to, those stakeholders in certain instances were mentioned as having a challenge in understanding the approach taken and thus engaging in it in a full-hearted way. And also, this was a singular point in time about the barriers and facilitators, and a single point meaning one service, and scaling up may need to include about looking at other areas. When I consider the notion of this within the practice setting, I can see that from this about identifying the barriers and enablers is good when we talk about implementation of evidence-based practice, because with this we're able to see what may be stopping us from bringing about the change that we need. This also illustrates this participatory approach that organisations can take. I know in certain instances this may be co-design or co-production, but we're asking the relevant people to be in part of this. And this indicates this proactive approach is as enabling people to plan services ahead about activities and developing them further, such as this nurse-led service. And equally, by involving those within the subject matter, they can also be the ones that can provide the solutions and insight to this subject area, and may be able to help us to design it even further and extend the service to encompass all aspects. Also, as part of this side of things was that this can actually inform change. And when we talk about change in terms of its sustainability, by involving those affected by the condition and those around them, by them buying into the notion of what we're trying to do, may enable that service to progress further and what they're trying to achieve. And what is also worth noting in this, which is seen globally and nationally, is the shortage of human resources from nursing staff as an example, but also the requirement of knowledge to be able to fulfill and support people in the care that they deliver. So with this side of things, as my final thought, I'd like to say thank you very much for listening to me, and please refer to the JBI Evidence Implementation journal website for further details of this article.